Thank you, Chairman, for your kind words. At the outset, I would also like to thank the organizers for such a wonderful conference and for this particular topic that was given to me. From the muscles, we now move on to the lungs, which is also a very unusual or not discussed, very often discussed complication of diabetes. So diabetes and the lung disease is my topic. The lungs are one of the most important organs in the human body, and we cannot survive without the proper function of lungs. And new findings have shown that there is a link between diabetes and various types of lung disease, both in type 1 and type 2 diabetes as well. So now, diabetes is a systemic disorder. We all know the entire conference is talking all about all the organs that the diabetes involves: heart, kidney, retina, brain, and vascular system. And there is not much work done on the lung as such. So in 1976, it was the first time this person, Euler et al., for the first time reported a reduction in the lung elastic recoil in type 1 diabetic patients. And since then, there have been a few studies that we find in the literature. Diabetes and the respiratory system, when we, as you can see here, diabetes with the smaller green arrows, you find all the other organs. But when it comes to the respiratory system, there are many more complications. You have asthma, which is increased, COPD, which is very much increased. I'll come to that a little later. And then there are lung injuries which are caused by pulmonary vascular bed, alveolar tissue, alveolar surface. Then there are infective diseases, both viral, bacterial, fungal, and protozoal, which are more common in the people living with diabetes. And cystic fibrosis is also known to be more, and lung cancers are more, and obstructive sleep apnea, of course, we all know about it. So this, all these slides are taken from the literature coming from 2019 onwards. So diabetic lung disease, is it a fact or a fiction? So we have, reduced lung function and reduced forced vital capacity, reduced lung dynamic compliance, peripheral airway obstruction, and reduced pulmonary diffusing capacity as well. Okay. Then we have all these conditions that that can be faced by the person living with diabetes because of neuropathy as well, autonomic neuropathy, parasympathetic and sympathetic, and impaired ventilatory response to hypoxia. So normal individuals, if there is a situation of hypoxia, they can respond better than a person living with diabetes. Reduced mucociliary clearance as well, increased lung infection because of that, and then reduced respiratory muscle strength. Again, muscle strength. Anubhav will agree with this. And respiratory muscle dysfunction as well. As you see, as sarcopenia, it is also seen in the respiratory muscles. So this is what happens. You have, non-enzymatic glycation. This is a pathophysiology. Non-enzymatic glycation of collagen and elastin, expansion of the interstitial tissue, an accumulation of inflammatory cell, pro-inflammatory, pro-fibrotic cytokines release, and oxidative stress that occurs much more in people living with diabetes. And there is a macroangiopathy and microangiopathy. So then this resulting into narrowing of the alveolar space and flattening of the alveolar epithelium, thickening of the alveolar basal lamina. So this is the basic pathophysiological mechanism of lung damage. So this is called diabetic lung. Diabetic lung is abnormalities in the ventilation control, bronchomotor tone, lung volume reduction, pulmonary diffusing capacity reduction, and neuroadrenergic bronchial innervation. Recent studies in mouse models of type 1 and type 2 diabetes demonstrated that diabetes causes pulmonary fibrosis. This is another condition which is least talked about. We all think of idiopathic pulmonary fibrosis, but I was also surprised when I went through the literature that pulmonary fibrosis is very common in diabetes, and we often miss the diagnosis, and people suffer from that, and it is irreversible. So both types of diabetes trigger increased DNA damage and impaired DNA repair as well, and leading to persistent DNA damage signaling. So release of pro-inflammatory and pro-inflammatory cytokines and growth factors, finally resulting in fibrosis. That's what happens. So let's talk about a little bit about what happens in hyperglycemia induced lung disease. There is hyperglycemia promotes airway hyperresponsiveness via the RHO associated protein kinase ROCK pathway, that is. And then hyperglycemia also accelerates lung fibrosis, as I just said. And then it also increases cancer cell growth, chronic inflammation, inflammatory cytokine release, and oxidative stress. And then hyperglycemia promotes susceptibility to pulmonary infections of all kinds. So this is what is the result of remaining in hyperglycemia. So the crux of the point is controlled diabetes. So type 1 diabetes, what happens to them? Type 1 diabetes, there is a mounting evidence showing that the lung is a target organ for diabetic injury, the beginning of the disease in pediatric age. So this is also, need to be thought of. The deeply branched vascularization of the lungs and the abundance of the connective tissue makes them vulnerable to the effects of hyperglycemia, similar to the other organs affected by the microvascular complications in type 1 diabetic as well. So biochemical mechanisms and signaling pathways potentially involved in the diabetes lung disease. What is depicted here, that is the polyol pathway, protein kinase, C pathway, and all these pathways, oxidate and all that. And there is something about insulin which can also affect the lung. Insulin inhibits the surfactant and surfactant protein E production via phosphatidase 3 kinase pathway. Then insulin also promotes mast cell survival, degranulation, and histamine release via P1-3K pathway, and activates pulmonary inflammatory macrophages. Insulin can also enhance lung disease to some extent. Insulin inhibits the proliferation of T helper cells in type 1 diabetes. It has been studied, and shifts T cell towards T helper cell in type 2 diabetes response. So now a little bit about the infection and tuberculosis, which is very common in our country. Diabetes reduces the immune response, we all know, and it may also increase the risk of developing active tuberculosis by approximately 3-folds as compared to the non-diabetic individuals. And diabetic patients are also prone to develop drug-resistant tuberculosis. Anti-tuberculosis treatment failure as a result, and disease response after the completion of treatment, and increased mortality in patients living with tuberculosis and type 2 diabetes. So there is a alveolar residential cells, that is monocytes and macrophages, play an important role in the pathogenesis of tuberculosis for every individual. And so Mycobacterium tuberculosis infects alveolar macrophages, and pathogen accumulates in the and replicates in the macrophages, resulting in cellular death and shedding of bacteria to the other pulmonary cells. This is enhanced in type 2 diabetes. So, coming to the COPD, yes, COPD, diabetes can cause COPD and vice versa. COPD in turn can lead to diabetes because of management itself, because of the stress that a COPD individual faces in life. So there is diabetes, as I already mentioned, an inflammatory disease. Then there is a structural alteration in the lungs, and there is diminished pulmonary function, and there is bacterial susceptibility. This will progress COPD self. COPD also is a systemic inflammation and metabolic syndrome, and high dose corticosteroid therapy in associated with COPD therapy can induce diabetes. Then COPD leads to development of diabetes, is it? Yes. All these factors which are seen in a person with COPD can definitely lead to diabetes. These are the possible mechanisms. I don't that because is known the systemic inflammation is common to both. Then ultimately insulin resistance, hyperglycemia, and then now diabetes and COPD complications are also much more in a patients with living with COPD. Pneumonia, respiratory failure, stroke, and acute kidney injury are higher in COPD hospitalizations with. Now, a few points about yesterday I was talking to somebody about my topic, and they said aspergillosis. Yes, aspergillosis is much more common, just like HIV patients. Even patients with diabetes, because of low immunity, aspergilloma is commonly seen or more common in people living with diabetes. So it affects the and treatment of this depends on its severity and whether it has resulted in organ damage. And if the organ damage occurs, it is a very difficult condition to treat, but it is treatable with methotrexate and again glucocorticoid. What is Aspergillus scan of lungs? Now coming to clinical questions, answers from evidence. What do we see? These are various studies done, and it has been proven that there is definitely diabetes affects the lung functions as quality of this slide. And does asthma affect glycemic control or vice versa? It has been studied that yes, diabetes affects asthma, and asthma again treatment as well as the stress can induce diabetes prone patients and push them to type 2 diabetes. So can diabetes worsen outcomes in COPD patients? Yes, as I already mentioned, there have been a lot of studies done which have. Now coming to the OHAs and corticosteroids in COPD and diabetes control, corticosteroids also have shown inhaled corticosteroids. I want to mention a few words because inhaled corticosteroids are known or said to be safe, but on a long-term usage can push the patients into diabetes. So what should people with diabetes pay attention to in relation to the lungs? People with diabetes and their treating physicians should pay attention to any changes in the lungs as they go along. Frequent dyspnea at low levels of exertion can be a first sign of the long-term effects of the diabetes on the lungs. Breathing problems persist, the lungs should be examined. Diabetes and smoking are a dangerous combination, and that can severely and permanently damage the lungs. Smoking cessation, how should we prevent pulmonary problems? Smoking cessation, ensure blood sugar levels, this is the that is the crux of all the treatment, and get vaccinated against influenza and pneumococci to prevent serious infections, get enough physical activity, and reduce sedentary time, and keep moving most of the time. So before I thank each and every one of you, dear friends, please don't neglect exertional dyspnea, or especially women coming to your clinics saying that I'm having a breathing difficulty. Of course, we think of heart failure, but if you rule out heart failure, next thing to think of is the lung disease. And I thank you for your patient hearing.